Hello, I'm Jay Schubert, DO, professor in the primary care department at Touro University, College of Osteopathic Medicine in Vallejo, California. Today we're going to be talking about insulin and how do you know you're on too much insulin. And our guest today is Sandhya Manavannan, MD, family medicine diabetologist. And we're looking forward to a very good discussion. So lots and lots of people are taking insulin. This is something that has really become a movement within primary care. But how do you know somebody's on enough, and how do you know when they're on too much? And what are the signs that I should be looking for as a busy clinician?
As you mentioned, many people are on insulin, and one of the major things that we look for in managing diabetes is hypoglycemia. So that's one of the hints that someone may be on too much insulin and too much basal insulin. So your morning blood sugar goal should be between 80 to 130. A lot of times people may experience hypoglycemia, and this happens a lot of times at nighttime because your insulin sensitivity is very high at night. And also your responses to hypoglycemia are also dampened at night. So those are two things that kind of really worry us as clinicians. So a patient may be experiencing a low or an episode of hypoglycemia, and they are not able to react or feel it physiologically. So having their typical symptoms of diaphoresis, hunger, lightheadedness, shakiness. At nighttime, your sympathoadrenal responses are dampened. So having an episode of hypoglycemia, either aware or unaware, is one hint that someone could be on too much basal insulin or insulin in general.
So I don't have many patients who come to me and say that they're having hypoglycemic episodes. So how do I start that conversation with them?
One thing that can kind of give you a hint is their A1C. So you can check their A1C, and if their A1C is almost too good, meaning 6.5 or kind of under that range, they might be actually having undetected lows. Whereas their average, because an A1C is a capture of a 3-month average, may look good, but they may have unaccounted for lows and highs. So a hint you can do when someone's A1C may be a little bit too good is you can have your patient check their blood sugar at night. So set an alarm and check their blood sugar around 3 a.m. or 4 a.m. and see if they're having dips in the night that are going undetected.
And you talked about the glucose being a way to help identify that. What's the pattern that should alert me that my patient could be dropping low at night?
So there is an effect called the Somogyi effect that may affect this. It is a theory that you could have an episode of nocturnal hypoglycemia and therefore have a rebound hyperglycemia in the morning. Now, this effect is a little bit controversial, but if you're having your patient titrate their basal insulin based on their morning blood sugars may be looking a little bit higher than what is truly happening in the nighttime. So that may be one thing to take into effect when adjusting a patient's basal insulin and so on.
So if I heard you correctly, you're saying I look at the blood glucose readings, and if I see lots of variability in the morning, sometimes high, sometimes not, I could ask the patient, why were you running high that day? And if there's unexpected highs, that could indeed, be indeed that rebound effect you mentioned.
Correct.
Okay.
And the other thing with basal insulin is sometimes practitioners, we tend to over-basalize patients. And that phenomenon comes from us trying to keep the regime simple for patients. So we want to keep them on one type of insulin. Patients don't want to take multiple shots a day. But as we know with physiology, after anyone eats, you have a postprandial spike. So after you eat any kind, you have a postprandial increase in your blood sugar. Now, a lot of times patients may actually need mealtime coverage. And as practitioners, we're kind of hesitant to start that mealtime coverage because patients don't want to take multiple shots a day. But in fact, that is the most correct for many patients because you need to target that mealtime spike. So a lot of times people end up on too much basal insulin because we keep titrating the basal insulin dose based on that morning blood sugar, which is only one point in many points of blood sugar during the day. So that's kind of how some patients end up over basalized.
Yeah, boy, I think that's a really important point. we had someone tell us this week that they only take basal insulin, and then we asked them to check their sugars later in the day, and they were pretty good the whole day despite eating. And then so we asked them, well, what happens if you miss a meal? And they said, oh, I would drop low. So would that be another example of being over basalized?
Exactly. So, your basal insulin, you don't want it to be at a point where if you miss a meal, then you go under 70. Your basal insulin ideally is to keep you in that kind of 80 to postprandial 180 range. If you could keep your patient throughout the day during that range, they should have the luxury of being able to miss a meal and not go below 70. So that's actually a very good point. Yeah, if someone has to make every meal in order to keep their blood sugar at a normal rate, that's a hint of being over basalized.
So if you were going to summarize the most important things to make sure people are on the right amount of basal, what would be the 3 things you would tell them?
The first thing would be, what are your blood sugars? So are you having lows? Are you having highs? What is your variability looking like? Are you checking after meals? So getting more data points is one huge point. I would say the second point would be trying to detect if they have any undetected lows. So are they having episodes of hypoglycemia? And also educating your patient on the signs and symptoms of hypoglycemia. Sometimes patients may not associate those symptoms of not feeling well with an episode of hypoglycemia. So education on what low blood sugars feel like, what they look like in terms of numbers, and how to see if they're having numbers that are going undetected.
So great point. So make sure your patients who take insulin give you data, not just for you, but for them to identify hypoglycemia. Make sure you talk with your patients about hypoglycemia, the signs and symptoms, and then give them the tools to look at the glucose readings and say, this is a warning, you could be having lows, let's talk about it.
Yeah, exactly.
Well, great. Well, thank you so much for your time today and your expertise, and we look forward from hearing you in the future.
Okay, thank you so much.
Thank you.